Hello everyone, and welcome to this audio podcast. This audio podcast as part of a Biome edition. This audio podcast as part of a Phantom Newscast. This audio podcast as part of a Lobostics Vortex. This audio podcast as part of a storm and cyclone bonus. In this audio podcast, I look at a um, a research poster presentation, originally from 2003, a research poster presentation from 2003, and looking at the importance of reduced nephrotoxic immunosuppression in pediatrics, in pediatric renal recipients, in pediatric renal recipients to ensure sort of to ensure sort of to ensure sort of prognoses to ensure prognoses beyond and between 10 to 20, but also beyond 20 years, beyond 20 years, and where the original research poster presentation looks at sort of a comparison in some regard to different immunosuppression, looks at a comparison to different immunosuppression. In around 20 in around 2020 in around 2021 in around 2021 2022, an article had been put forward to the biomedical scientists, and the article is sort of an addition to the original research poster presentation from 2003. So in this audio podcast, there will be a look sort of at aspects of the research poster presentation from 2003, and sort of look at aspects of the works from 2021 and 2022, and where jointly the work is under the theme in regard to the science of nephrotoxicity. So, as part of this cyclone bonus, and as part of this Biome edition, so biomedical scientists, immunologists, and clinical scientists tend to collaborate best when there is a consensus in investigation of and in around transplantation amongst pediatrics. Collaborations are also successful when there is a determination to ensure safe efficacy of immunosuppression therapy. And for listeners out there, one of the acronyms or abbreviations even that is used for immunosuppression, for example, is IST. And so collaborations are also successful when there is a determination to ensure safe efficacy of IST therapy or IST with reduced side effects. To identify best possible transplantation and match for pediatric sufferers or pediatric renal sufferers, and to allow prolonged renal function, serology laboratories focus on cross-matching and paneling techniques organized in laboratories. The important investigations for possible cross-match include, for example, lymphocytotoxic investigations and mixed lymphocytotoxic culture investigations, and both are forms of tissue typing. A clone match, referred to as an identical match, can't be established unless the pediatric recipient is a twin with when an isograft allows survival or prognosis of and in amongst renal transplants, sort of by default almost, quite easily between and beyond 10 and 20 years post transplantation. So donors such as live from living relative and cadaveric recipient, where recipient receives a donor from someone who's pronounced as brainstem dead, have also retrospectively been appropriate. Now, in regard to a little bit around the major histocompatibility complex. So the major histocompatibility complex, or MHC, and the human leukocyte antigen, the HLA, characteristics are not identical except in amongst where HLA and MHC, where in amongst living donors, MHC and HLA, or where HLA is concerned, there are higher probables where there are less mismatches, and where there is generally a greater match complex. Cadaveric transplants, at the same time, or sort of alternatively, at least in some regards, and in amongst literature retrospectively have informed sort of the greatest risk of rejection. That being said, in works published in around in the late 90s, early millennium, there was works published in, for example, nephrology, dialysis and transplant, or NDT, that informed that amongst some of the data at that time, that there had been less the risk of rejection between those who have live transplant living donors, and those between cadaveric or from those who are pronounced as brainstem dead. For example, the prognoses in data from the NDT works from the late 90s, early millennium, had informed that the prognosis between the two was not all that different. So whilst cadaveric transplants have shown the greatest risk of rejection, and can be sort of a decent, where there can be decent cross match if carefully selected in amongst for post transplantation. A sibling to sibling donor where HLA complement is similar should have, for example, 7 or more years prognosis, and with greater differences of MHC and HLA characteristics between pediatrics, the chance or the probability of a prolonged functioning renal allograft A renal allograft, for example, uh, is and can be reduced. Can be reduced. Rejection of transplants tend to occur mainly through cytotoxic T cell effects. So immunosuppression and the probable nephrotoxic side effects also cause challenges. T cells tend to aid in detection of antigens and destruction of allografts, and helper cells aid in appropriate recognition of and in amongst them where the in amongst where HLA and MHC is concerned. Thus, there will always be there is always there is always or can and can in the majority in the majority, and especially in amongst pediatric renal sufferers, unfortunately, there can be some form of allograft rejection. Now, as part of this works and the additional aspects of the article the additional parts of this article and sort of additional to the research poster presentation from 2003. Now looking at cross matching, and we're cross matching looking at cross matching in regard to also age matching. So unlike other transplants, the kidney or renal pathophysiology, in regard to renal pathophysiology, that has the kidney has what is referred to as ABO antigens articulated on the endothelial cells of blood vessels. If the donor recipient has different blood group complex from a different blood group complex from recipient, then the antibodies will result in a type 2 hypersensitivity reaction in the renal allograft and will cause elimination of a transplant through, again, the cytotoxic T cells. T helper cells also aid in the acknowledgement of transplants binding to explicit areas of the MHC. Allografted recipients or grafted recipients might also have some HLA through rejection of a preceding allograft. This applies to pediatrics more so than in the adult population, because where pediatrics who may have had more than one transplant, for example, owing to for example, where in amongst particular where in amongst where pediatrics where diagnoses of particular conditions, particular illnesses, particular conditions, for example, are for example are not the same. For example, are not the same as those in amongst the adult renal population, for example. So a variety of renal illnesses have associations with the MHC. The first of these to be illustrated was an association between DR2, which DR2 referring to a particular loci or a locus of part of the MHC, where there was an association between DR2 and antiglomerular basement membrane disease. Subsequently, several different MHC alleles have been coupled with other renal pathophysiology, other renal pathophysiology and conditions. So laboratory investigations for MHC typing are are and have been advancing from serological to molecular methods methodologies. These investigations are frequently or have been frequently have been frequently used have been frequently used and do not have, but at the same time do not have not are frequently used are frequently used, but at the same time, in particular specialisms, specialisms do not have a place in routine or everyday clinical practice. Complementary to the MHC, several other genetic indicators that may be linked with a variety of renal diseases are being or have been explored or investigated, but these are also currently solely for research intrigue. Research also informs that kidneys from old donors into young recipients should be avoided, and these kidneys, for example, should be given to age-matched recipients. Now looking at immunosuppression and nephrotoxicity. So transplant pharmacotherapy has pharmacotherapy sort of advances as new agents and pharmacotherapies are investigated and approved for use. Solid organ transplant recipients depend on multiple can depend on multiple immunosuppression or IST, given in combination, given in various combinations, and given also where MHC and HLA are closely cross-matched, for example, or where the cross-match is between where tissue typing is concerned, then fortunate recipients can there have been cases amongst the literature where recipients can be on single or solo immunosuppression, and where there has been a case where, for example, in more recent times, for example, where amongst the pediatric population, where there has been a case where a pediatric is in regard to post-transplantation had not required the use of immunosuppression or IST at all. So the patients or recipients are often can require other therapeutic agents to treat underlying conditions or concurrent conditions. Wherever pharmacotherapy is administered to transplanted recipients, potential exists for increasing or decreasing tissue concentrations of IST. This can lead to complications such as over IST and infection. Clinical immunosuppression or clinical IST has been plagued, unfortunately, with maintaining a balance between allograft rejection and transplant we maintain a balance between allograft rejection of a transplanted organ and complications of over IST or over immunosuppression, including for example, infection and malignancy. So laboratory teams with clinicians must understand current IST regimens and associated effects post transplant. And whilst all transplanted recipients receive some form of IST pharmacotherapy, except in whereas sort of informed, there have been cases. There has been a case where IST pharmacotherapy has not been required. The combinations and choices increase as novel pharmacotherapies are developed. In the critical and acute sort of settings or environs, newly transplanted recipients will likely receive induction therapy. So induction therapy in amongst the literature is also referred to as mainstay therapy. So mainstay therapy or induction therapy is where recipients have a baseline IST or form of IST, and then depending on how HLA and MHC are in context of tissue type and cross matching, then recipients may be on dual therapy or triple therapy. And so therefore in amongst peds in amongst young people, where they're transplanted, for example, the the general pathophysiology in amongst peds is and can face unfortunate issues through their time. So in the critical and acute environs, newly transplanted recipients will likely receive induction or mainstay therapy to increase long-term allograft prognoses, and whilst preventing or reducing rejection or reducing allograft rejection. An understanding of the mechanistics and mechanism of action and additive effects of drugs or pharmacotherapy allows healthcare professionals to optimize whilst decreasing adverse effects. IST therapy offers potential for reducing detrimental patient outcomes, for reducing detrimental patient outcomes, but also at the same time they can improve allograft prognoses, but additionally can in recipients can also cause harm. Pharmacotherapy has been one of the major concerns in amongst renal medicine, where nephrology is concerned, and it is becoming more complex as more pharmacotherapies are introduced. In particular, anti-rejection therapy for PED recipients, and because of the nephrotoxic substances enhanced in one's immune complex. In amongst one's immune complex, there is concern of for example secondary conditions. So, for example, vascular complications in both specialisms. Amongst pediatrics and young people, and adults, the recipient can be treated sufficiently. In ped recipients, it is also additionally challenging. Excuse me. It is additionally challenging for treatment to aid aspects of of lifestyle because of tests and investigations tend to be sort of frequent in amongst peds and young people, thus interfering, for example, in schooling and academic performance. At the same time, specific medication pharmacotherapy for peds for peds have many can also have many toxicological effects and can affect well-being. So during the past decade or so, several new potent IST pharmacotherapies with different modes of action and different side effect profiles have become available. IST after a renal transplantation, for example, is at the same time no longer one single regimen applicable to all recipients. And in the selection of optimal immunosuppression protocol, immunosuppressive protocol, individual drug-related toxicity, recipient-related risk factors, as well as donor organ characteristics have been considered, and amongst specialists tend to still be considered. So at the same time, as part of this works, or as part of this audio podcast, to inform all immunosuppressants or ISTs have different modes of action and efficacy surrounding safety profiles. Scientists or lab and laboratory specialists prompt the appropriate therapeutic indices for medication to be prescribed by clinicians so that there is a reduced toxicity impact in pediatric renal recipients. The pharmacokinetics of older IST drugs, including for example cyclosporin A or CSA, tacrolimus or FK506, mycophenolate MMF, and or sirolimus or rapamycin are generally complex but also comparable. A narrow therapeutic index unique to each recipient, as well as variable absorption, distribution, and elimination and characteristics of these pharmacotherapies. Therapeutic drug monitoring, or TDM, plays a fundamental role in helping clinicians maintain blood and plasma levels or concentrations. Variation in concentration outside the narrow therapeutic ranges can result in adverse clinical outcomes. TDM ensures that concentrations are not too high or too low, and as per mentioned, in regard to tissue typing and cross-matching, where transplantation is specifically concerned, and the scientific investigations where scientific investigations have gone into have transitioned into more sort of molecular methods where serology, for example, is concerned, and where TDM is concerned, therapeutic drug monitoring is concerned. There have been advances in regard to TDM. For example, TDM determination is through, for example, through and has been in amongst various laboratories. For example, the use of high performance liquid chromatography, which is used for TDM therapeutic drug monitoring of the active ingredient or the active metabolite, mycophenolic acid, and the active metabolite in mycophenolate. And TDM of tacrolimus has been improved has been improved with development of assays or immunoassays with greater sensitivity and specificity for tacrolimus than those previously available. So it is important to identify a specific pharmacokinetic parameter for each individual, whether it's trough levels or parameter that is referred to as AUC, or area concentration under the curve. Under the curve, which may be most useful as a methodology for optimal therapeutic drug monitoring in scientific practices. TDM or therapeutic drug monitoring guidelines also help ensure quality assurance and safe practice toward transplanted recipients. All IST is associated with drug-related nephrotoxicity or impaired renal function. Despite advances in IST, major improvements in treatments have been required, especially in a reduction in nephrotoxic side effects and a rigorous definition of the relationship or association between drug concentration and clinical effects. Such improvements are achievable with more second and third generation IST of second and third generation IST. At the same time, the preferred modality for renal recipient for renal replacement the preferred modality for renal replacement is generally through transplantation, and its superiority in prolonging the longevity of pediatrics diagnosed with forms of the longevity of pediatrics diagnosed with varying forms of renal disease, and by determining end stage renal disease, or ESRD, is important and in terms is and continues to be pivotal in terms of quality of life. In terms of quality of life, pediatric surveys indicate that renal transplantation is and tends to be better than other forms of renal replacement therapies. So in summary, so during the past decade or so, several new potent IST or immunosuppressant agents have, with different modes of action and different side effect profiles, have become available. IST post-transplant is no longer, again, a sort of a one single regimen applicable to all recipients. And in the selection of optimal immunosuppressant protocol, individual drug-related toxicity and recipient-related risk factors, as well as donor organ characteristic, must be considered. All immunosuppressants or IST have therapeutic indices that can induce nephrotoxicity, which is difficult to distinguish in allografted recipients, and is still a particular issue in the setting of renal transplantation. Minimizing immunosuppression or or IST-induced nephrotoxicity improves allograft prognosis. However, to obtain a significant long-term improvement in allograft outcomes, it may be necessary to adapt new IST regimens. Challenges facing scientists, biomedical and clinical and immunological and clinicians should now be focusing on addressing at the same time equality, education support, and burden and in regard to burden of disease post-transplant or post-transplantation. That draws this audio podcast to a close. This audio podcast this audio podcast as part of a Biome edition. This audio podcast as part of a Phantom Newscast. This audio podcast as a part of a Lobostics Vortex, and this audio podcast as part of a Cyclone bonus, and this audio podcast as part of a Storm Lobostics production. Thank you.